Today we will be continuing our discussion on gastrointestinal symptoms with a focus on bowel obstruction. We have Dr. Vineetha Rijju joining us for the day, and for her introduction for the session facilitation, I hand over to Dr. Sridevi. Ma'am, over to you.
Good evening, everyone. And once again, thank you so much for joining. As Sripriya was mentioning, today we'll be dealing with another topic related to gastrointestinal symptoms, which is very commonly seen in a palliative care setting. And once you understand how to assess and diagnose and understand the various conservative management strategies, you can see how you can change a patient's life dramatically. And this is very, very commonly seen and mostly mismanaged symptom in many of the hospital setting. And they come up with a lot of unnecessary or futile interventions. And the moment you start identify and start treating this in a proper way, you can see how much impact that you can create in their life. So this is one of that kind of symptom, I must say. Thank you, Dr. Vineetha, for coming once again, and over to you.
Thank you so much, Dr. Sridevi and Sripriya. And big hi to all the participants. It's nice to see you back again today. And today we shall be looking into the rest of the GI symptom that is planned for the session, that is on how to manage obstruction. Right? I shall just try to share my screen. I hope my slides are moving. Is it?
Yes, ma'am. Perfect.
Okay. Right. So yes, so today we will be looking into bowel obstruction, and what we will be looking into is the classification. What are the different kinds of bowel obstruction? And what are the different symptoms that is going to tell you, yes, this is the case of bowel obstruction, and also how to actually come to a diagnosis. And once you do diagnose, what can you actually do about it? And how do you actually manage bowel obstruction in palliative care? So I'm sure many of you have seen cases of bowel obstruction. And like Dr. Sridevi was saying, it's quite distressing symptom, very commonly seen and often mismanaged. So we shall be also looking at a case report. And this is what we will be discussing in later after today's session. So Sarah is a widower of 62 years old, and she was diagnosed with CA stomach, 4th stage, with metastasis to the peritoneum and anterior abdominal wall. And she had a palliative distal gastrectomy also done, and she was also given chemotherapy. But just after 2 cycles of chemotherapy, a CT scan taken showed that she had already progressed further in her disease. So this is a case that we will be looking into further. Okay. So now comes the classification. The classification of bowel obstruction. So what will be the 2 major type of bowel obstructions that you know of? The 2 major types, right? Which are the 2 major types? Yes, can all get on the chat box? What are the 2 major types of? Yes, acute. Dr. Manjri says acute. Yes. Well, if we have an acute, we're going to have a chronic here also, right? Yes. So we have acute, chronic, based on, whether it happens all of a sudden or it is just keeping on happening over time. Subacute, Dr. Eustace says subacute. Yes. Very commonly seen. We see subacute intestinal obstruction in many of the patients, especially in palliative care. Then what about the site? Based on the site, what may be? Yes, Dr. Gregory also says it could be partial or complete. Absolutely. Yes. And what about the site? Based on the site, can you classify them into small bowel and large bowel? Dr. Eustace says is absolutely right. Yes, Dr. Anish also agrees, upper GI, lower GI, absolutely. And what about if, if it is in the intestinal wall, outside the intestinal wall, or inside the intestinal wall? Yes. What would that be? How would you classify them? Intraluminal, yes, Dr. Anish says it could be intraluminal. So likewise, if it is outside the lumen, we would call it extraluminal. And if it is inside, within the lumen, you would call it an intrinsic obstruction. Okay. Yes, Dr. Smitha also agrees to it, saying it could be luminal, extraluminal, or intraluminal. Okay. So that's exactly what our classification is. And also, it also depends if we have an obstruction or not, right? So whether we have something over there which is obstructing it actually, or is it a non-mechanical obstruction, right? So what are the causes of non-mechanical obstruction? The ileum is basically paralyzed here. It could be a functional obstruction. It could be adynamic bowel. Can you give me a very common reason for it? Yes, Dr. Jennifer says electrolyte imbalances. Electrolyte imbalance, like say hypokalemia. Yes, a lot of you will agree to that. I have Dr. Smitha, Dr. Jason says paralytic ileus, yes. And Dr. Anish also agrees to hypokalemia. Absolutely. So hypokalemia is one of those very, very commonest things that we see that produces paralytic adynamic bowels. And you do not even hear bowel sounds. You auscultate the patient and you do not hear bowel sounds. But one thing that stands apart from mechanical obstruction is also that there is less pain in non-mechanical obstruction. Now, coming on to mechanical obstruction, well, most of you already did say that, the different types based on the speed of onset, it is acute, chronic, acute on chronic, subacute. Then based on the site, you have small bowel, large bowel. Based on the nature, it can be a simple obstruction, it can be closed loop obstruction, or it can be strangulated. And based on the etiology, it can be intrinsic, extrinsic, or it can be intraluminal. Now, what can be the reason for mechanical obstruction? What are the causes? What could be the causes for? Yes, Dr. Smitha says there could be a mass. So what adhesions? Dr. Arnav says adhesions. Dr. Anish also says mass. Dr. Newster says tumor progression. Yes. So there are so many reasons. It could be a mass, the tumor, or like Dr. Jennifer is also saying strictures, adhesions. Yes, there are so many reasons for why someone could have a mechanical obstruction. So dynamic obstruction, the bowel is capable of contracting normally, which is not in case of adynamic bowel. And in dynamic obstruction, there is even excessive contractions, probably proximal to the obstruction. So what is that physical, what is that we observe on physical examination when there is excessive contractions proximal to the obstruction? On physical obstruction, on physical examination. Yes, Dr. Jennifer also says volvulus can be a cause. Yes. So what is that when you physically examine the patient and there is excessive contractions? Yes, Dr. Aisha says visible peristalsis can be seen. Even Dr. Arnab agrees to that. And yes, Dr. Gregory also agrees to that. And what happens when you auscultate such a patient? Increased bowel sounds. Yes, Dr. Newster says increased bowel sounds. You call it the Borg-Agni bowel sounds, right? So that is also seen. And again, we had also seen that according to the nature, it can be simple when there is just one obstructing point. There is no vascular compromise. And then you have a closed loop type where there is obstruction at 2 points, forming like a loop. And what happens between the two obstructed sites? The middle part starts getting grossly distended. Okay, now this is one situation where there is higher risk for perforation. Then you have strangulated type, where the blood supply is compromised. Now, these kind of obstructions, they are very painful. Yes, and they can have signs of mesenteric ischemia, where you have blood in stools, severe pain, vomiting. All right. Yes, Dr. Jennifer was also saying about distension. Yes. So now let us go on to what are the different causes for mechanical obstruction. So like we were already discussing, there can be a mass over there. So there can be intraluminal causes, that is, there can be impaction, like there can be fecal impactions, there can be foreign bodies, bezoars, gallstones. It can be intramural, where it can be a stricture or it can be malignancy. You have something outside the intestine, extramural. It can be adhesions. Probably the patient has had radical surgeries, or the patient has had radiation. So all these can produce adhesions. Hernia, volvulus, intussusception. These are all different causes for mechanical obstruction. And yes, you have the adynamic causes, which is paralytic ileus, mesenteric occlusions that happen, and pseudo obstructions that happen. Okay. Now, what are the symptoms that your patients will present to you with? What are the symptoms? Yes, Dr. Anish was saying the strangulation will need emergency surgery. You're absolutely right. But, you know, again, when you talk about emergency surgeries, I would like to say that in palliative care, this is very important. In palliative care starts right from the time of diagnosis, right? So we are dealing with patients who are on active treatment, probably for cancer, and then it is probably in the early days, palliative care is not playing a very huge role like how much the definitive treatment is playing. But as time goes by and the disease progresses, the definitive treatment role kind of starts coming down and palliative care takes up. So when you're managing the patient in the initial few days, we are all on. Even in palliative care, we are all on. We take into consideration the quality of life of the patient to the maximum. Again, even when it comes towards the last days, we are also taking quality of life to the maximum, even at that point. But our intervention differs. The interventions that we do or the management of the symptom differs in the early days and towards the terminal phase. So you are absolutely right when it comes to managing a patient with mesenteric ischemia with emergency surgery. But if you are looking at a palliative care patient towards end of life, we will have to think otherwise. Right? So I was also talking about what are the symptoms, and lot of you have given me here a lot of good answers, like Dr. Jennifer was saying vomiting. Dr. Manjari also agrees to that and says abdominal pain that is colicky. And again, we have also Dr. Anish putting in additional points like guarding and distension. And yes, Dr. Gregory also adds on to saying that there is abdominal pain, distension, vomiting. Yes, Dr. Shalina says there is abdominal pain and vomiting as well. Dr. Bounty says there is bloatedness. And Dr. Newstar would like to add that not passing stools and flatus and abdominal distension. Yes, so that is absolutely right. So we are going to have patients who are not passing stools or flatus. That comes in a case of complete obstruction. And you will have patients who might present with abdominal colic. You might have patients who present with bloatedness. nausea, vomiting, etc. So why does this happen? This is why it happens. Colicky pains, there is bowel contractions. Now, this is because there is a distension of the bowel. There is increased bowel contents. There is increased gut secretions. Epithelial surface area is increased, which in turn increases the bowel secretions, right? And also because of the partial or the complete bowel obstruction, this is also adding on to the colicky pain. Now, the bowel distension is also contributed because of the obstruction, there is decreased movement of the intestinal contents. So what happens? There is a further accumulation of the bowel contents. This makes the bowel distended and distended. There's an increase in the gut surface, epithelial surface area. This could lead on to inflammatory responses, which can cause continuous pain. Again, bowel distension and increased bowel secretions could add on to nausea and vomiting. So these are the different reasons why your patient is presenting you with the following symptoms that you were talking about. Now, how are you going to make a diagnosis? Where is this? Where is this obstruction? How are you going to make a diagnosis on that? Now that you know this is an obstruction that you are looking at, how are you going to make a diagnosis as to, okay, this is an obstruction, probably at the probably in the small bowel or in the large bowel? Well, Dr. Jason says take an abdominal erect X-ray. Yes, Dr. Anish also agrees to that. And Dr. Anish also says we could take even a CCT of the abdomen. Yes, Dr. Charlene says there is to look at the nature of the vomitus. Would you like to add a little more on to that? Thank you so much for that point. Dr. Charlene, would you like to add a little more on to that? What exactly of the nature of the vomitus? Yes? To kind of give you a hint, yes, Dr. Jennifer was saying it could be bilious. So if it is bilious, it's probably the upper GI. Yeah, it could be the small bowel. Dr. Charlene was saying it could be blood tinged or altered blood or bilious. Yes. And Dr. Smitha was saying it could be bilious or non-bilious. It could be feculent. Yeah. So they can be fecal matter also if it is a complete obstruction that you are looking at. Now, this particularly happens for lower GI obstruction, where you can have a feculent, vomitus. Okay. So now, moving on to, so you were all telling me about, yes, we need radiological investigations like X-ray, abdominal erect, or CCT, and also you can ask about the nature of the vomitus. So you are all right in your own ways. But what happens in palliative care is that sometimes you are seeing the patient at the bedside, at his home, where we do not have actually the scope for radiological investigations. So we might have to depend on history taking, right? So level of obstruction determines the pattern of symptoms. If it is a high level obstruction, the vomiting develops early and it is more large in volume. If your patient is telling you that, doctor, I do not know from where I'm vomiting so much, I'm eating or drinking so very little, but I'm vomiting in huge volumes, you need to understand this is a high level obstruction. Then for large bowel obstructions, they are rather progressive, and the abdominal distension is more prominent in case of large bowel obstructions. Now, when it comes to complete obstruction, the patient will tell you, I'm not passing motion, I'm not passing flatus either. And sometimes the patient could have spurious diarrhea. So just because there is leakage of fecal material in terms of spurious diarrhea, do not think that it is not an obstruction. So always keep your points behind your mind as you look at the patient so that you do not miss something which is so important and which is so common in palliative care patients. Yes, so like you all rightly said, when it comes to imaging, we have the erect abdominal X-ray. And very typically seen, you see multiple air fluid levels. You can also go for CCT, contrast radiography with gastrographin, right? Now coming on to planning and management. Yes, so you have diagnosed your patient. And now you have to plan the management. Yes, Dr. Charlene was asking here, what if it is combined, such as in peritoneal dissemination of cancer? This is also a common presentation when there is disseminated metastasis. Sometimes in peritoneal malignancies, they can be obstruction at different levels. So the symptoms might be perplexing. You might not be able to actually pinpoint where exactly the tumor is. But again, when it comes to multiple obstruction points because of the disseminated malignancy, most often your patient is in the terminal stage, and it is more about symptom management. So you are, your focus kind of goes on towards, only managing the symptom. Now, yes, so Dr. Anish was saying that double bubble, triple bubble, etc. in X-ray can also help in the differential diagnosis. So if possible, we can carry a portable bedside ultrasound. And Dr. Jason will, oh, okay, so that's a personal message. So then, yes, you can also have a portable bedside USG, but sometimes in home care, we do not have such facilities. So we might have to resort to these kind of history takings, right? So coming on to how you are going to plan management of your patient. So how are you going to manage your patient? It is an obstruction. So how are you going to treat your patient? Yes, so Dr. Aisha says NPO, keep the patient NPO, IV fluids, Ryle's tube aspiration. Yes, any more? Okay, so your patient has come to you with symptoms of obstruction, abdominal pain, vomiting, not passing motion, or flatulence. Dr. Anish says antispasmodics. Yes. Dr. Aisha also says antispasmodics. Dr. Manjari also votes for pain management, antiemetic. Dr. Anish says cyclopam, buscopam. Wonderful. So absolutely. I mean, when we look at patients who come to you with bowel obstruction, it should not be just the diagnosis in front of us. It is that individual with the symptom. So treat the symptom. The patient has come to you with immense pain. If he does have pain, you treat the pain. If the patient is vomiting, you try to give antiemetics to bring down the vomiting. Okay, and definitely side by side, you plan your management. So let us see. Yes, Dr. Shabnam was also talking about bowel decompression and hyoscine and antiemetics. Absolutely. We would also, especially in case of small bowel obstructions where the patient is severely distressed with large volume of vomitus, you would like something to bring down the secretions also. So here, your hyoscine butyrate bromide buscopan is going to come in action. Okay, it's going to be of help. And again, Ryle's tube, you can be inserted for bowel decompression. Now, again, with the consent of the patient, ask the patient whether you can put in a Ryle's tube. Okay. And Nilper oral in palliative care, we usually advise that you can give sips of fluid and check for if the patient is able to tolerate it in case of chronic obstruction that the patient sometimes present with. Is there any role for flatus tube is what Dr. Anish was saying. Well, flatus tube also helps to decompress the bowel. So it can be tried. It will give, if it can give symptomatic relief for the patient, definitely it can be tried. But again, most often the gaseous distension is proximal than distal. So it's often the rise tube probably that can also be of help, but definitely we also do try flatus tube. So coming on to planning and management, who are we going to advise surgery? Who are we going to conservatively treat? So that is what this is about. Okay. So you have a patient coming to you with symptoms of bowel obstruction. You clinically assess the patient. If the patient has to be investigated radiologically, you do that. And you make a decision on what next. There are some things we should be in the back of your mind, like what are the patient factors that are going to tell you that you have to go for aggressive management, or what are the patient factors which tell you that you have to go for conservative management. And again, likewise, you also have some disease factors. Okay, so when it comes to patient factors, again, the first on this list is age. But let me tell you, age is just a number. What you need to give more importance to just that number is the performance status of that patient at that age. Because most often we see very healthy individuals even at the age of 80. So check for the performance status of the patient. You can follow the Karnofsky's, or you can follow the ECOG performance status scale. And if the patient has a good performance status, this patient could be a candidate for aggressive treatment. Now check for the stage of the cancer. If it is a metastatic cancer with disseminated metastasis in the liver and peritoneum and all that, this individual probably is not a candidate for surgery. Further anti-cancer treatment options. So always discuss with the oncology team. Always discuss with the oncology team what are the further options that we have. Because we know that, say, even when it comes to chemotherapy, there is definitive chemotherapy which intends cure. And then we have palliative chemotherapy, which does not intend cure, but it helps to bring down the burden of the disease. So discuss with the oncologist if there are options for palliative chemos for this patient. Or if there is any other surgeries like colostomy, any ostomies that can be done. Now, malnutrition and cachexia. So these are all poor prognostic factors, cachexia. So if cachexia has set in, probably your patient is not a candidate. And other concurrent illnesses. What if your patient has got diabetes, cardiac disease, and a number of other concurrent illnesses? This will be against one of the factors which you could think for aggressive treatment. Now, coming on to disease factors, what is the level of obstruction? Is it just at one point, or is it at multiple points, like you were talking about earlier, right? What if there is small bowel level obstructions and large bowel level obstructions because of the disseminated peritoneal malignancies? So they are all poor prognostic factors. Now, site, is it a proximal, is it of proximal, or is it of the distal bowel obstruction site? And whether it is a functional obstruction, mechanical obstruction, whether there is a situs, or whether it is a carcinomatosis peritoniae. So all these can be like ascites, carcinomatosis peritoniae are all factors which are against a very aggressive treatment. Okay. Now, also there are technical factors which contribute to your decision making for malignant bowel obstruction. That is a degree of invasiveness, interventional radiology, endoscopy, laparotomy, laparoscopy, anesthetic requirements, or you need to get expert opinions on how further you can contribute to your decision making. So who do you advise surgery? Who do you advise conservative management? This is what we were talking about. So this is what we were discussing. Advanced age with cachexia, it's a no. Widespread tumor, deranged metabolic parameters, it's a no. Ascites, low serum albumin, severe nutritional deficiency, all these are a big no. Palpable abdominal mass, previous radiotherapy to the abdomen and pelvis, it is going to be difficult. And history of combination chemotherapy, if there has been a history of multiple chemotherapies being given, that is first line chemotherapy, second line chemotherapy, and multiple levels of chemotherapy has been tried for this patient, it itself says that this patient is of poor prognosis and low responsive to treatment. So that would also be a no for surgical management. And then you have multiple sites of obstruction, that is also be a no for surgery. Poor peristalsis due to diffuse carcinoma peritoniae and poor performance status also would be the reason to say a no for surgical prognosis, for surgical intervention. Okay. Now treatment, you have pharmacological treatments. Yes. So what do? You give laxatives, right? You can give enema, you can give. So what other laxative would you like to try? Since we have finished our so what other laxative would you like to try? Yes, Dr. Shaleen was asking, usually we see a combination of ascites and obstructions, so ascitic tap as and when required. Definitely we can go for a ascitic tap, but it is also giving you a hint that there is disseminated peritoneal metastasis, which is probably contributing to the ascites rather than just a low albumin level, right? So what are the different laxatives that you can give for this patient? Yes, we know of bulk enhancing laxatives, you know of high fiber laxatives, you know of stimulant laxatives. Bisacodyl stimulant, Dr. Shabnam says stimulant laxatives, yes. Stool softeners can be tried. Bisacodyl stimulant laxatives can be given. And generally, we do not encourage for bulk enhance, for high fiber laxatives, which would in turn increase the bulk of the fecal matter because already there is distension, right? So all these can be used. Then we have also corticosteroids. So what is the action of corticosteroids here? Why do we want to give corticosteroids for a patient with malignant bowel obstruction? To decrease the edema is what Dr. Shabnam was saying. Yes, Dr. Newstar also says reduce the bowel edema and pain. Yes, Dr. Annie also adds on to that, reduce mucosal edema. Yes. Well, there is this question by Dr. Aisha, shouldn't stimulant laxatives be avoided? Well, that it would be if your patient is in immense pain. So probably you could think otherwise. You need stimulant laxatives might not be a first choice, right? Yes. So we also have other answers coming in here, like Dr. Smitha was also saying reduce wall edema. Dr. Jennifer says reduce the inflammatory edema. Dr. Aisha says anti-inflammatory. Dr. Rajani also says decrease inflammation. So basically you have a tumor mass there which is obstructing the lumen. So you give corticosteroids to decrease the peritumoral edema. So this in turn decreases the edema and gives a little space in the lumen. So you have this tumor mass which is obstructing the lumen, and when corticosteroids are given, there is a decrease in the edema all around the tumor, which is going to create some space, and there is going to be some gap in the lumen. Okay, so which corticosteroid do we use most often? Which one do we use? Yes, we have answers here. Dr. Anish was saying hydrocortisone, Dr. Jennifer says DEXA, Dr. Shali, Dr. Newstar, Dr. Aisha, Dr. Arnab, Dr. Shabnam, Dr. Rajni, everybody agrees to DEXA. Dr. Sanchia says hydrocort. So we need something which has a prolonged action. We go for dexamethasone. And we go for a high dose of dexamethasone. Generally, I give about 24 milligram IV once daily because it has a prolonged action. And I would like to give it in, before the evening hours because it could hinder with the sleep of the patient. Okay. Now we have also antiemetics, which has to be given. Antiemetics, again, we can go for prokinetic antiemetics because it will help to propulse the fecal matter to kind of help with the peristaltic waves. But if your patient is having abdominal colic, it might aggravate by using prokinetic antiemetics like metoclopramide. So we can go for others like buscopan, like haloperidol, or ondansetron. Again, ondansetron also has some constipatory effect. So you can choose your antiemetics accordingly. Anticholinergics, yes, you can use hyoscine butyl bromide, somatostatin analogs like octreotide, and analgesics to address the pain of the patient. You can go for a severe pain. Definitely, you can go by the ladder. You can give morphine, although it does have a role. It does have an effect to cause constipation. Yet, for severe pain, definitely morphine is never a contraindication for bowel obstruction. And then surgical is resection of the bowel segment, colectomy, ileostomy, colostomy. Now, the problem about ileostomy is that there is always frequent drainage. It is high volume drainage when compared to colostomy. So it is very distressful actually for the patient who has an ileostomy. Of course, we know that it is very distressful even having a colostomy, but ileostomy is even more difficult to handle. Then invasive procedures like NG tube insertion, gastrostomy, and colonic stent are also other interventions that we could try. So, well, antiemetics, yes, metoclopramide, that is a dopamine antagonist. You can start with 10 milligram, 8-hourly subcutaneous, gradually increase the dose day by day, or in for higher doses, 30 to 120 milligram over 24 hours can be set on your continuous subcutaneous infusion. Okay. Then again, you can give 5-HT3 antagonists, and prokinetics only in partial obstruction can be used. Then haloperidol for nausea and vomiting. You can start at about 2.5 to 5 milligram in your continuous subcutaneous infusion. Or you can even give it 8-hourly if you do not have a facility to start continuous subcutaneous infusions. Now, corticosteroid is here. Dexamethasone is advised 16 milligram to about 24. Sometimes it is given up to even 28 milligrams per day, and generally given before earlier part before evening, and it is given as a 3-day trial. And you check if the patient responds to the corticosteroids, whether the patient is developing bowel sounds, whether the patient has started now passing flatus. So these are all signs of responses that you get. by checking for corticosteroids action. And if vomiting subsides, you can then switch over to oral steroids. Steroids act by reducing the peritoneal edema. You can also give somatostatin analogs like octreotide. 300 micrograms per day can be given in divided doses. So what it does, it reduces the secretion, slows down the motility, it reduces the splanchnic flow, it increases the absorption of water and electrolytes. It's a potent anti-vasoactive intestinal peptide effect is what it has. And it can also be given as a preventive step. You can give depot preparations. But generally, we do not go for depot in preparations very commonly in palliative care cases. And especially, they're very expensive. Octreotide itself is expensive. Depots are all the more expensive. So most often we go for other anti-secretory agents like hyoscine butyrbromide. Along with steroids, somatostatins can be given. So this is what your prescription for the patient is going to look like. Dexamethasone 8 to 16 milligram, or sometimes even more according to the patient. It is you plan it, customize it basically for each patient. And it can be subcutaneous, it can be given IV. You give a 3-day trial, and metoclopramide can be given 30 to 120 milligram, 24-hour subcutaneous infusion, or in divided doses. Hyoscine butyrbromide, an anti-secretory agent. Haloperidol can be also tried for controlling the vomiting. Now, metoclopramide and hyoscine butyrbromide, the reason I've written or is because you cannot give both of these together. You have to be careful that you do not give both of these together because it cancels each other's action. Metoclopramide is just going to help propulsing further by promoting prokinesis, whereas butyrbromide, hyoscine, is going to, it acts as an antispasmodic. So do not combine the two. So you can give metoclopramide if there is no colic, or if there is colic, you can give hyoscine butyrbromide. Okay, right. So we did talk about chronic stenting. This is how a stent would look like. And you can see that the expandable stent, how it actually opens up the lumen. So it is not that we advise stenting for every patient. It is preferably done for patients with a good performance status, especially those with a good prognosis, because there is no point doing a stenting for a patient who is going to live only for 3 weeks, right? So you go for stenting for a patient who has a better prognosis in terms of his disease, and also when there is only a single obstruction site. Now comes the common FAQs. What about hydration of this patient? How much of IV fluids are we going to give? Because you did say that you would like to put the patient nil oral. So how would you plan hydration for this patient? Yes, IV fluids. Yes, Dr. Newstar was asking, you don't give IV for these. Yes, we are giving IV for all of these. And in, like I said, in palliative care, sometimes in the home setting, if we are not able to get IV access because the patient is very sick or hypertensive, sometimes it's easier for us to put a sub-Q, and which the family also can manage. Okay. So coming on to hydration, yes, IV fluids, okay, I get answers like 60 to 75 ml per hour, IV fluids based on the deficit, IV and depending on the extent of vomiting. Yes, I mean, all of you are correct in all your own ways, and it is basically individual based. And Dr. Anish also says sips of oral fluid, and Dr. Mohammed says depending on the fluid loss. So what I would like to say is that, yes, there is some amount of obstruction. Your patient is just vomiting, not able to drink, eat. The patient is definitely dehydrated. So do not try to overhydrate your patient with too much of IV fluids, because they tend to because your patient is bedridden, the fluid tends to move on to the extracellular space. This can also add on to the secretions of your patient, which will in turn increase the vomiting. Now, that is an important catch over here. So you need to also balance your management on hydration. If your patient is able to tolerate oral sips of fluid, encourage that, because always how much of IV fluids you're giving, also the dry feeling in the mouth and the throat is also important. So giving small sips of fluid helps to make the mouth moist and make the patient comfortable. So that answers to the oral feeds. Would you like to give your patient solids? Maybe you have to wait. Maybe liquid feeds if the patient is tolerating, but otherwise clear fluids is what we advise. Okay, clear fluids is all that we advise. And total parenteral nutrition, when would you like to advise your patient? Yes. Well, Dr. Anish was saying if NPO for more than 48 hours, consider TPN. And Dr. Arnab says, according to the urine output, you can think of the IV fluids. And Dr. Shabnam is again telling of the TPN. I don't think won't do much, plus the complications with TPN, and it's also costly. And yeah, right. And Dr. Arnab is also saying to take care of the insensible loss also and based on the weather. Yeah, so we are getting answers here on TPN. Why should yes to TPN or no to TPN? So the answer is that it depends on the prognosis of the patient. If your patient is likely to live for more than 3 weeks, maybe your patient is a candidate for TPN. Otherwise, risk versus benefit. The complications of having a TPN cannula. Okay, now earlier we used to have TPNs which are only given through the central line, but now we have TPN, we have parenteral nutritions which can be given through peripheral line. But still, total parenteral nutrition is not generally recommended for those patients who have a prognosis lesser than 3 weeks. Okay, and nasogastric tube and gastrostomy. Now, gastrostomy, again, it depends on the prognosis. If your patient is having a longer prognosis, maybe. Nasogastric tube, yes, for decompression. But again, if it is for decompression and that too for a very temporary time. And now, when it comes to terminal patients, your patient is having intractable vomiting, severe distension of the abdomen, which is causing a lot of distress to the patient. So all this, hematemesis, all this, you can put in an NG tube. And you know what I usually do? I mean, most of these patients, they feel so thirsty, they feel so hungry. They have not drank or ate for many days. So it doesn't help by telling them, no, but you know what? You have an IV fluid. What your body needs is going through here. There's no point in telling that to them because they feel thirsty. They are feeling hungry. So now what we need to think in case of terminal patients is that, is it actually justifiable keeping them away from all these things which they are actually wanting to do? So sometimes when it comes to terminal patients and, you know, I have them on nasogastric tube because of intractable symptoms and they say, doctor, I just want to eat something. I just want to drink something. I just tell them, you know what, just give a bit. I tell the family, just give a bit because whatever they eat is anyways going to come out through that rice tube and go into the bag. So if it is in situ, sometimes in case of terminal case, I do say, but of course, we have to be very careful that they do not aspirate on it. So when you do want to say something like that, always keep the head upright because your patient as it is has a potential to vomit. Yes, Dr. Nari was saying the TPN might be of high volume. And Dr. Manjari was saying the TPN only for patients with good prognosis. Yes. And Dr. Smitha was like difficult to maintain TPM sterile in a home setting. And yes, Dr. Anish was talking about the peri-CABI one. That is a peri TPN, right? So now we come to the case. Sarah, the widower, which is supported by her children who are living in the UK. Okay, so now we know that she's pretty much on her own. All her family is in the UK. So which also tells us that she is financially capable of undergoing any higher end treatment. Now that is also very important, because many of the patients who are in for palliative care, who have a poor prognosis in progressive cancer, and they tend to be drawn into unnecessary interventions and treatments just because we can afford it. So what is important is that whether it is actually going to matter to that patient and increase his quality of life. Okay, and whether it is justifiable. The ethics of the medical ethics, no harm, do good, justifiable, and of course, autonomy. Does the patient want it or not? So Sarah is a 62-year-old lady diagnosed with stage 4 gastric cancer, metastasis to the peritoneum and anterior abdominal wall. She has a palliative distal gastrectomy done, and she was given chemotherapy. After 2 cycles, what happened is that she progressed. The disease progressed, and she developed vomiting, abdominal colic for 2 days, but was still able to pass small amounts of stool daily. Now, the vomiting was about 3 to 4 episodes per day, which was unrelated to meals, and the vomitus was bilious with partially digested food. Okay, so what does that tell us? She was not dehydrated. Her bowel was distended. Bowel sounds were sluggish. So what are we looking at? Where is the obstruction? What type of obstruction is this? What type of obstruction is Sarah having? Upper GI. Yes, wonderful. Dr. Jennifer says upper GI. Dr. Shalini also agrees to it. Dr. Manjari also agrees to it. It is an upper GI obstruction. Yes, Dr. Annie also agrees to it. So yes, Dr. Mohammed, Dr. Newstar says it could be subacute upper GI. Wonderful. Because there are bowel sounds. It's not a complete obstruction. Dr. Aisha says it could be extrinsic due to the peritoneal disease. Yes, she does have a radiological finding of having disseminated peritoneal disease. It could be extrinsic. And Dr. Sanchi also says it is upper GI. So now you see, we did not need a CT. We did not need a abdominal erect X-ray over here. But we know the history over here. We saw the clinical findings over here, and bang, we could just come to the diagnosis. This is a subacute intestinal obstruction. This is an upper GI obstruction. And this is exactly the principles that you need to apply when you see a palliative care patient, especially at a home care settings. And even if it is a patient at your OPD, you can prioritize in managing the symptom of the patient before telling, okay, shift the patient to the CT room. And there a lot of delay happens by waiting for the next person to get in. I mean, for the person who went in, or the queue is there for the, a queue of patients are there. And there's a lot of time that is lost over there. Before that, what you can do is that you can have a picture of what obstruction are you looking into and start managing your patient symptom-wise. So in view of the persistent vomiting, a NG tube was inserted for Sarah. And Sarah was told that the nasogastric tube insertion would be temporary, just for relieving her decompression. And now a CT scan was taken for her, and it showed a small bowel obstruction with a transient point at the proximum jejunum. But well, in this case, you see a CT scan was taken to show that, but you could already diagnose this was a small bowel obstruction. And as it was still open, as she was still opening her bowels, the impression was that it was a partial, that is, it is subacute intestinal obstruction. So the intent of management was to reverse the obstruction. So it was conservative. Okay. So what was the treatment that was given to her? She was given a suppository for bisacodyl and a regular interval intravenous metoclopramide, 10 milligram every 8 hours, and intravenous dexamethasone. So what do you think over here? This patient was a patient with vomiting and abdominal colic and with partial obstruction features. And this was the treatment given for her. She was put on bisacodyl. She was given regular interval intravenous metoclopramide and intravenous dexamethasone of 8 milligram per day. What do you see over here? Are you happy with this? Are you happy with the prescription? Yes? I don't see answers. So is this, do you think that the prescription was fine? Oops. Yes, a higher dose of dexamethasone is what Dr. Newster was saying. And then Dr. Shalini says the dexa is again inadequate. Dr. Aisha says fentanyl can cause constipation. And then the nutrition hydration has to also be looked into. Well, Dr. Anish says 8 milligram is not enough, or is it enough? And ODBD is not written. Well, do you see something over here? Patient had what? The patient had vomiting, the patient had abdominal colic and constipation, right? So, well, we are giving a support. They did give a suppository of bisacodyl to address the only small amount of motion that she is, fecal matter that she is able to pass. So probably to, help her more with that. And then again, regular interval intravenous metoclopramide is given. Now, what is your metoclopramide going to do for Sarah when she has abdominal colic? Yes. Dr. Anish says Buscopan instead of metoclopramide. Yes. Dr. Smith also says no metoclopramide. Yes. Dr. Jennifer says, yes, the pain is going to increase. Dr. Rajani says you have to give hyoscine butyrate. Yes. So exactly. So metoclopramide was given. And again, dexamethasone was given only 8 milligram per day. So probably she needs a little more higher dose. Now, what happened? We really know now what could actually happen. Metoclopramide was given, so the pain would have definitely increased. So that's what happened. She was started on fentanyl infusion for worsening of lower abdominal pain. Okay. Now, then no bowel action. The further the intravenous metoclopramide was increased, and then there was a clinical improvement for 2 days later. And she had a bowel opening, and the NG tube aspirate also started reducing, and she had no more vomiting. So then the team doctor told, okay, now we can remove your nasogastric tube. And Sarah was started on oral. And intravenous metoclopramide and dexamethasone were continued for 2 days, and it was stopped. So what happens here? And it was stopped. So you think that we should have just stopped it? 3 days later, she started vomiting again. She had 3 episodes of vomiting in a day, which contains moderate to large amount of bilious vomiters. She is recommended on IV metoclopramide 60 milligram per day, dexamethasone 8 milligram per day, and again, ranitidine 150 milligram BD was added to reduce the gut secretions. So why did she develop these symptoms again so quickly? Why did she develop these symptoms so quickly? Well, she was given the same things. She was given metoclopramide, dexamethasone, all that even before. And it was started, and just 3 days later, it just started all over again, right to square one. Dr. Charlene says it is progressive disease. But now we are talking about 3 days, right? So what happened in these 3 days? She was given on a combination of medicines, and it was stopped. It was stopped. Now that is what we need to take in consideration. It was stopped. It was stopped early. It was not tapered. Okay, so that is what made the symptoms come back so fast. So this is a learning point here, that when you stop your patients on antiemetic, when you are converting your patients from IV to oral, you can do that, but taper it down, check for the symptoms, and then stop it. Especially your patient who has, like Sarah, who has multiple peritoneal metastasis, where the risk for recurrent like these episodes are possible. So always taper your medicines. You might have to taper down even steroids, dexamethasone. Put your patient on 4 mg dexamethasone for about a week, and then taper it down before you stop it. So now, symptoms were persisting. Now, the goal of care was established after discussing with patient and the family. And Sarah said that she preferred to keep the nasogastric tube for decompression while she enjoyed taking the fluid orally. And decision was also made to stop further chemotherapy and go for comfort care alone. So she returned home with home hospice support. So that was the case. That is the case report of Sarah. And we do see where things went wrong and how things could have been probably, managed better. And here we do see that the family has been away and the goal of care was discussed only later, much later. So probably these things are those that had to be done way in the beginning, even when she was diagnosed with stage 4 disease. What are the goals of care for Sarah? Who should be she linked to so that she gets support in times of need? Okay, so and now I would just like to mention also about bowel irrigation. So why is bowel irrigation done? Why do we go for bowel irrigation? Yes, why do we go for bowel irrigation? Bowel irrigation is done for those with colostomies. And the reason we go for bowel irrigation is because this helps to regularize the bowel, evacuating the bowels at a particular time of the day. So what is done is that for 21 days at a stretch, bowel irrigation is done by the patient, and it so happens that after that, the bowel itself comes into a habitual kind of process of opening only at that particular time of the day. Otherwise, what happens for colostomy patients? There is always the bag filling up, and this prevents them from interacting with the crowd, from going out from their homes, even getting back into their occupations. So doing bowel irrigations help them to come back to life, basically. So these are the different things that is used for bowel irrigation. You have an irrigation bag, the tubing, the cone tip, which is inserted into the stoma. There's the clip. This is the irrigation sleeve you see there, and the ostomy belt. So this is how the patient is placed. So warm water, lukewarm water is filled in the irrigation bag, and you saw the cone tip over there. That is inserted into the stoma, and the water is let to run through the stoma, through that cone tip, okay? And it is clamped. And after a while, the cone tip is removed and the sleeve is attached, and the contents, the bowel contents are let out into the commode. So as of now, we know how to classify intestinal obstruction. What are the symptoms that your patient could come to you complaining of, which can give you the hint that this is bowel obstruction that you are looking at, and also how to diagnose bowel obstruction without any frills of radiological investigation, at least to a point. And again, how to manage your patients, who to treat conservatively, who to treat aggressively, and treatment in palliative care patients, especially when it comes to terminal patients, where we treat them conservatively, and about Ryle's tube, how to hydrate these patients. All this we have dealt in a nutshell. Okay. So thank you very much. That is all about bowel obstruction. And I think now we can move on to today's case presentation, and after that probably we will have time for discussion.
Thank you, Dr. Vineetha. Yes, as you said, we'll take the case presentation now and we'll move on to the discussion later. Dr. Anne, you are muted. Can you just unmute and talk?
Good evening, all. Am I audible?
Yes.
Yes, you are.
Hi, I'm Dr. Anne Mary. So, next slide. So today's case is about a 70-year-old male. He was having colonic obstruction and a diagnosis of a carcinoma retrosigmoid stage 4 with also altered sensorium, dysphagia, and acute febrile illness. So the patient presented with fever associated with chills and rigor for the past 2 days, and he is having an altered sensorium and dysphagia. Next slide. The history is like he was having abdominal distension on and off, lower abdominal pain for 2 months with intermittent altered colored stools associated with no vomiting and blood in stool. He underwent sigmoidoscopy and biopsy, making a diagnosis of retrosigmoid stage 4, carcinoma retrosigmoid stage 4 with multiple liver metastasis. He underwent Hartmann procedure and a colostomy was done for him. The family refused oncological treatment because of his poor prognosis, and they're presently on homeopathic treatment. He was very independent and he did all his activities on his own, but for the past 2 weeks he's unable to do he's unable to get up on his own and is showing difficulty in swallowing, generalized tiredness, memory loss, confusion, etc. And he's having a continuous fever of 102 to 104 degree Fahrenheit for the last 2 days, and there is no associated pain with him. Next slide, please. So on examination, he's conscious but confused, febrile, pulse rate of 90, BP 130/90, and temperature of 102 Fahrenheit. Chest X-ray, ECG, everything normal. Next slide, please. So he's managed by IV fluids, antibiotics, and because he had difficulty in swallowing, and because of the altered sensorium and all, the Ryle's tube was inserted. And lab exam investigation is as follows. He has leukocytosis, elevated CRP, anemia, hypokalemia, and all. And he had multiple liver metastasis, so his liver profile was very deranged, and urine and blood culture was sterile. So, and CT abdomen also was done in that advanced carcinoma rectosigmoid junction with multiple liver metastasis, hepatomegaly, and minimal ascites was found. Next slide. As per psychosocial aspects, the patient was very active till his initial diagnosis and surgery. So the sudden diagnosis was shocking news for the family and the patient to accept. And the patient had stoma in situ, so it was very difficult for him to adjust and socialize. And he always used to tell the family he just want to get rid of it. And the patient was very pleasant and joyful, but now he's constantly irritated, angry because of his diagnosis and current state. The family takes care of him very well, and they're financially sound. He used to ride bike, and he was very independent, but now he has to depend on his son for everything, which made him vulnerable and sad. And the family also is very devastated on the diagnosis and deteriorating health of the patient. So, and the patient, the family complained that the treating hospital, they refused further on symptomatic care, since like they did not wanted to go on with the chemotherapy. So they also felt very helpless, like what to do next, like that. So currently he's on IV fluids, antibiotics, and all those, and stool toughness and all. So major concern is altered sensorium dysphagia. And for the last 2 weeks, he's completely bedridden. So there is stage 1 pressure source. So the family is managing with mupirocin ointment, and also it's like managed. And rapid deteriorating health is also a major concern. Next slide, please. Summary, colonic obstruction, carcinoma, rectodermal, stage 4 with altered sensorium, dysphagia, and acute. Next slide, please. So actually this, I'm currently not working, so this patient is a known to of mine. So I just, my main concern is like a palliative aspect, what all we can do for this patient. So what all we can provide for a better management, and how to counsel the family and patient to support, face this situation. And for the hospital, should they suggest a palliative care instead of denying further on care? These are my concerns. Thank you.
Thank you, Dr. Ann. We'll wait for a few minutes for some chats from your batchmates. What do they think about how to manage this patient? What all ways we can provide a better management? I think should the patient and family be provided with support to face the situation? I think everyone might be a little bit clear that we need to. But I think how to support the family and patient to face the situation might be something that we would like to discuss today. Yes, we are getting a few chats. Most of us are still unaware that palliative care can be given and impact the patient and family members in a big way. Yeah, Dr. Nusya, we are literally waiting for you all to start doing this practice and let us know how you could bring in an impact on the patient and family. What was your experience? And really looking forward to that. And whatever I think so far the lectures we have covered, I hope you understood that all the faculty members were talking from their experience. It's not from any textbooks. Like, of course, they refer textbooks, but whatever the case discussions happened or whatever inputs they were giving is mostly from the experience that they have had in their palliative care practice. There is another comment from Dr. Shaleen that altered sensorium possibilities like septicemia, hepatic decompensation, so not symptomatic. Thank you, Dr. Shaleen. Can you just go down? So Dr. Manjari is telling, of course, palliative care is needed, but unfortunately, it is non-existent in so many places. And along with patient and family at times, the treating clinician don't know how to guide. Very, very true, Dr. Manjari. Yeah, I think that's although some clinicians really want to do something, they may not be understanding like how to go ahead with that and what kind of support they can provide. Or sometimes they may be alone in a hospital and they may not get support from the fellow colleagues or even in the staff from their own department. Dr. Nari is telling even without a palliative care unit, supportive treatment can still be given. Very, very true. You don't need to be a standalone palliative care physician to do all this management that we were talking. Anything you take, pain, communication, GI symptoms, any topic you take, you don't need to be a standalone palliative care physician. You can always incorporate these principles in whichever specialty you practice, no matter like what specialty you are in. Like even if you are not directly in touch with patients, that there are certain instances that you come across where you can we can. I think you remember when someone presented a patient where the diagnosis was randomly told by the lab technician, they overheard. So everywhere you can have these principles applied, which can change a lot of things in patients. Like very, very valid point, Dr. Nari. Yeah. Dr. Vanti is telling evaluation of goal of treatment, nutrition support, and symptom management. Very important point, that is the goal of treatment. To understand for ourselves and to communicate that to the patient and family is where it should start from. Otherwise, we'll be aiming at something and they'll be expecting something else. So having that, fixing that goal along with patient and family, very valid point. Yeah, Dr. Newstar is telling, sorry, in between I missed a comment. The nutritional support and further communication for symptomatic treatment. Yes, that's what they want. They don't have much options. They want to know how they can. I'm sorry, Dr. Vineetha, my voice is going down and down and down. So I hope you can read it from now on. And I can see Dr. Arnab's hand in between. You can just tell him to.
Do you want me to read it for you?
You can take the discussion from here.
Yeah. Dr. Newstar is also saying my observation regarding your relative, Dr. Annie, is that since he is confused, he may be having pain. So how do we assess pain in such situations? Well, I think Dr. Anish was saying that, yeah, it could be done based on the heart rate and restlessness and all that. Very correctly said. Also, you could look at the facial grimaces, like, if it is a colicky pain, maybe the face is kind of calm at a certain time, and then at times there is an entire grimace that you see in the face, or maybe the hands are moving towards the area of pain. There are things like that, or when the patient is being turned, there is, patient makes more of noise, or all these can also be hints that the patient is in pain. Anything more that you would like to add, Dr. Sridevi, on that, on how to assess pain in patients with encephalopathy?
No, I think nothing more to add to what you said.
And Dr. Jennifer was also saying about counseling and communication. And Dr. Shaleen was saying, sure, patient needs general nursing care, feeding, prevention of bed sores, general hygiene, and allowing time to family to accept. Yeah. And that is also right, because rather than waiting for bed sores to happen and then manage them, the most important thing is prevention of bed sores. So especially in bedridden patients, good back care and pressure sore cares should be given, pressure point cares should be given, so that this can be prevented. And regarding constipation in this patient, is bulk laxative acceptable? Bulk laxative may not be the first choice that is given for such patients. You can try stimulants. You can give enema into the ostomy also. So suppositories are also given into the ostomies if the patient is having constipation. And always, sometimes even digital evacuation from the ostomy has been done.
Dr. Arnab has raised his hand.
Okay.
Dr. Arnab?
Yeah. So I think what went wrong with this patient was the hospital completely refusing to kind of give further help and advice when the family members couldn't agree to curative treatment. So what happens is in my experience is that there's a authoritative consultation where the doctor gives one solution to one problem, and if that solution is not acceptable or not possible by the relatives, there is no second or third option. So the practice of negotiating, reaching common grounds, uh, collaborating with the patient in their own health treatment is kind of lacking in medical system of India, is my experience. And the I think the root cause of the problem is the medical training itself, because what happens is when somebody is trained, I'm just giving an example. When somebody is trained in OG, even if there's a simple high sugars, you refer to an endocrinologist or an internal medicine. I had a patient in internal medicine with grade 1 UV prolapse and was being referred to an OG clinic just to teach Kegel's exercise. I think it's the lack of general practice knowledge in our medical education system which actually causes this problem, where something that is beyond the specialty of one field is kind of referred to another person, and the communication is not that great. So if our medical system was compartmentalized into specialties with good communication between professionals, then I think that would have solved the problem. But here, one person says, I will take care of your heart, go to a nephrologist, see your kidney, go to a neurologist, see your brain. If nothing works out, go to a psychiatrist to see your pain. If nothing works out, go. If you're a cancer patient, go to a palliative medicine specialist. So everything is very compartmentalized, and the whole picture which palliative medicine sees as a whole is not very prevalent in other specialties. Uh, is my understanding. I am I'm okay for any comments on this from other participants also. Is that it's I think the problem is the undergraduate training, which does not give the expertise to see a person as a whole. So I think that's where just giving one option, the my way or the highway, you don't listen to me, I can't treat you, go somewhere else. That kind of approach is, I think, the problem in most places, as I have seen, especially in North India. Thank you.
Hi, I'm Dr. Sanchia, and I'm so sorry I differ from the views just now because I'm great friends with the palliative care team, especially the home care team at Rajiv Gandhi Hospital, and they're doing brilliant work. They have an awareness program at IBAS Hospital in Delhi. We have also awareness programs. It's on timely basis. So we also have they have tumor boards, and they discuss about all the aspects of the patient. And they have a social team that is this is Rajiv Gandhi regarding cancer. They have a social team where they try and help out. And then there are schemes by the government. There's a president scheme where they can write and get help. In our setup in IBAS, it is totally free. So it's a Delhi government setup. And we do send them to healthcare groups. I do have right now a couple. I always have, say, about 2 to 3 Guillain-Barré syndrome patients. And when it comes to children, especially children who've come from Punjab and staying with their relatives here for better treatment, now there is palliative peace. There's a movement which has started in Punjab. So these are all places where they pitch in. And now that the movement has caught up and many people are getting aware, so there is specialists from all who put their input, and it's the basic treating physician who assimilates this and works with the patient as to what best can be given. Like whatever hydrocort is available with us, we start off by giving that when it comes to steroids. And we have a few vials of dexamethasone, so we use that. And then we send for LP, that is local purchase, because local purchase takes 1 or 2 days to come for the patient, but it is given. And these are things that are being done currently. And I just wanted to create a little awareness that North India is not what it used to be. There is a can care social program with palliative care, and they're doing good work, especially in the slums and a little underprivileged area. The Max team also is working very hard, and of course, they cater to the elite crowd. So nowadays, awareness of palliative care is there in North India, and slowly they are providing holistic care. And it's very nice to see that there are many young doctors who are taking up this cause, and they are contributing in their specialty. Like we have psychiatrists who come for just when they have their off or free time, they come and they work with the patients. And that is something nice. Formerly, it was not that. They would just be government doctors, they would be overburdened and just work on that. But now, because they're doing research work, I've seen personally a few people. So on their Sundays, when they do research work and they take a break, and the patients approach them, they don't shy away. They actually sit down and see what has happened. Because when some patient is approaching you, it means he needs help. It means he has something to say. And that works actually. Like NHS, we don't have that feedback loop where it is considered as to how the patient feels, what feedback for the system. We don't have that, but we have a very strong moral code among people. And I truly believe that people are genuinely helpful, especially when it's their loved one who is sick. They're very open to suggestions. So this is my feedback on it. Yeah, thank you.
Thank you, Dr. Sanjay. I think, Dr. Arnab is telling it's. I also feel the same. It's great that things are happening and things are changing, but I think there are still millions of people who do not have access to any palliative care services, not even the basic pain medications. But I'm glad that things are changing and the wonderful work happening in your place. That's so amazing to listen to, actually. And so, but still, as Dr. Shaleen and Arnab was telling, many places, even in Kerala, we say Kerala, the most covered in terms of palliative care. Still, there are places where people do not have access to good palliative care service. So that's the reality. Yes, Dr. Anish, please go ahead.
Yeah, I'll just off my video so that it'll be better audible. Because I have network issues. So whatever we just heard, I think it is two sides of a coin. So basically, it's like government funded trust, and some funding is there. They're doing a great work. They're coming forward with palliative care things and everything. Patients are getting care. When it goes to a private hospital or where the money is involved, uh, hospitals are suggesting surgeries and active management for patients who actually require palliative care. That is actually a factor, a monetary factor, not to point any fingers at anyone. These private hospitals also need to survive. So they don't offer palliative care. Once that just like the doctor said, once they refuse the treatment suggested by the surgeon, they will just ignore the patient. So, and it's the same when it comes to the patient side also, that I have noticed if the patient is having a health insurance or like ECHS, like ex-service military health scheme. So there is no financial burden on the family. And if the patient is like in the disoriented state, the bystanders tend to go for all the treatment. They opt for all kinds of treatment because there is no financial burden for them. They don't think in a palliative care point of view. They just say, okay, do whatever you want because they are not in a financial burden. And in the end, we say that we are sorry. They are not worried about it because they know that the financial part is taken care of and they have a mental satisfaction that they have given maximum, whatever care they can get. So that misunderstanding of the relatives that a maximum care to the patient is actually a ventilator or a surgery, that is a misunderstanding of the general public, wherein they should understand that their relative or a parent should have a dignified death instead of a struggling ventilator life. And many a times these relatives are very selfish when compared to the, I mean, when what ethically matters. They say that, okay, my daughter's marriage is after 2-3 days, so you just have to prolong the life of the patient in a ventilator. So and there is no financial issues there. We are forced to do that because ultimately it's a wish of the relative when the patient is actually unconscious. So that is what I wanted to add. Thank you.
Thank you, Dr. Anish. Yes, I totally agree. Most of the points. And I think, Dr. Vineetha, you have experience in working in a corporate sector for many years, and you managed to be with the team for quite some time, right? So maybe you'll be able to talk a little bit about that. I know we are diverting from bowel obstruction, but I think this is also important for
This
today's
is a very important
discussion.
point.
Yeah.
And like, everybody was also contributing to it. Like, maybe we really don't need a palliative, a full-fledged palliative center to actually get palliative care happening. If you have a team who imbibes the entire principles of palliative care, and if you are able to successfully propagate it among your colleagues, and I think that's the best way possible ahead. And the initial days are going to be very tough. I have gone through it quite a lot. But definitely, when it comes back to patients giving their feedback, family giving their feedback, even after the death of the patient, that's the most beautiful part. Even after the death of the patient, when the family comes back to you and thanks you for whatever you have done, whatever your team has done, that's when you understand, and when the entire team understands, this is something beautiful. So I think a teamwork is necessary, and to get the principle of palliative care across, once you all go back, try to talk about palliative care among your colleagues and get them to understand the importance of it. And that's the only way that we can have a successful road ahead. And yeah, that's what I would
Just to
like to
add
say.
on to that, and I think, Dr. Anish, it's not completely dependent on the corporate or the government sector. Still, in the government cancer centers, there are senior doctors telling, don't go for palliative care. You are not there yet. You are not dying. Why don't you just continue with this treatment? Still happens in Kerala. So it's not because of the government or the corporate sector, but corporate sector, I have heard various conferences, like people like Dr. Biju, who works in the corporate sector for so long, how they've convinced the management that how effectively you can use the ventilator for someone who has a better prognosis or more number of patients than for a patient who's with the palliative care intent and for a prolonged period of time. So they managed to convince the management, the monetary aspect also, and the management was so convinced. So that's how I have heard from him. He started working in KIMS in Trivandrum for quite a long time, and then now in Rajagiri, which is another corporate sector. And there are in Bangalore, some of my friends work in a big time corporate sector hospital. They managed to convince the management that this has actually monetary benefits. I think even in Amrita also, it's a private hospital, still they have a full-fledged. But as Vineetha told, the initial steps are going to be really, really tough. But yeah, you will be able to make the change. And as Dr. Rajgopal always says, it took years and years in Kerala just to have the term palliative care familiar to people. So yeah, it's a hard work, but it's quite possible. Thank you so much, everyone, for the wonderful discussion. Yeah, Dr. Anish, maybe after the course, we'll help you to be in touch with some of the people who have actually started palliative care in the corporate sector from the beginning days. So you may be able to get some inputs from there, from them. That might be one way to go ahead. Like I have worked for a year in KMC Manipal, where they managed to get into the system right from the beginning. Didn't happen overnight. But as Dr. Vineetha said, everyone was aware of what palliative care could do. And they understood that if they incorporate good symptom control, their patients are going to be happy and come back to them again and again. So that took some time, but they have integrated in a very, very big way, even in ICUs. Yeah. So thank you so much, everyone, for the wonderful discussion, and we'll keep having these discussions again, and we can continue discussing the groups also. Thank you so much, everyone, and thank you so much, Dr. Vineetha, for sharing your experience and taking us everyone through the bowel obstruction management in a palliative care setting. Thank you so much for your time.
Thank you, Dr. Vineetha, for
Thank you, sir.
joining us from your busy schedule, and we hope to have you with us all the way long when we are spreading the news of palliative care in and around India. Thank you for joining us, and thank you everyone for joining for today's session. That brings us to the end of today's session, and till we meet again on 30th with another interesting topic. This is Sri Priya along with Dr. Vineetha Rijju and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you in the next session. Take care. Bye-bye.
Thank you, everybody. Bye.